Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello, I'm Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. Prone positioning. We know that it really emerged as a vital intervention in the management of patients with acute respiratory distress syndrome, as well as other respiratory conditions, and we really saw this especially during the COVID-19 pandemic. So this technique, which involves placing patients face down, and research has shown it can significantly improve oxygenation and ventilation, leading to better patient outcomes. Now, historically, what I saw was prone positioning was first documented in the 1970s, but it gained prominence in the 1990s. And studies have shown a 50% improvement in oxygenation for ARDS patients. So today, it is a standard practice in many of the intensive care units worldwide. Now, why is this important? Well, with respiratory conditions being a leading cause of hospitalization, understanding and implementing prone positioning really can be a game changer in patient care. And studies have shown that prone positioning can reduce mortality rates by up to 16% in severe ARDS cases. In this episode, we're going to delve into the whys behind prone positioning and why it's beneficial, and also the challenges of prone positioning. And this is to hopefully equip you with the knowledge and strategies to effectively use this technique in clinical practice. Now, joining me for this podcast is Kathleen Volman. Kathleen, thank you so much for being here.
Oh, Candace, I'm excited to talk about this topic. It's been near and dear to my heart since the first time I proned a patient in 1982.
Oh, wow. Well, do you want to tell our listeners a little bit about your background and areas of expertise? 1982.
Yeah.
Wow.
So I am a critical care clinical nurse specialist. I've been a critical care nurse for 45 years, 10 directly at the bedside, 13 at the bedside as a clinical nurse specialist for the medical ICUs at Henry Ford Hospital in Detroit, Michigan. And since 2003, I've had my own company, which is called Advancing Nursing, which is focused on creating empowered work environments for nurses and other healthcare clinicians based on skill, knowledge, and process improvement. So I have focused on critical care-related topics, ARDS, prone positioning, sepsis management, early recognition, and then also fundamental nursing care to prevent infections. So that our patients that are in the intensive care unit and elsewhere in the hospital don't get an infection that increases their risk of dying.
Yes.
So I am currently the president of the World Federation of Critical Care Nurses, and I'm also on the board of the National Pressure Injury Advisory Panel.
Wow. Such a diverse background. I am so excited to learn from you today. You have so much knowledge that I need. I'm so grateful that you're here.
Oh, I like to share that knowledge.
Oh, that's so good. Well, can you start us off with what is prone positioning and how does it benefit patients with respiratory distress?
Well, as you stated, prone positioning is oftentimes our patients are on their back or what is called the supine position with the head of the bed up, and hopefully from pressure injury reduction, we're turning them from side to side if they can't move. But this is a face down position or on their belly from a lay perspective. And most of the time, there is a slight elevation in the chest, in the pelvic region, to allow the belly to be free of restriction. And part of that is for improving full lung volume.
Right. Well, it reminds me of pregnancy, kind of that same
those
thought
pregnant
process
pillows.
there. Yeah.
An interesting point, I don't know if you're aware, but I actually invented a device to prone critically ill patients.
Oh, I did not.
Yes, I did that for my thesis in 1986. I patented it in 89, and Hillrom picked it up in 1997.
Wow.
So it was sold around the world. I was ahead of my time because
Yes, you were.
the seminal research really didn't hit till about 2013. So what happens physiologically, because I think it's important for them to
Yeah.
understand, when you're lying in a supine position, you have your cardiac structures and pressure against a rigid spine. So that creates your pleural pressure to be more positive, making your lower lung sacs in the dependent position tend to be closed. So it
Mhm.
takes more pressure to open them up. And so that could, if you're ill, affect your oxygenation. So in ARDS, one of the challenges is there are pockets in the lungs that are not working. The lung sacs are not working. They're either completely shut down, it's called shunted, um, or they are partially full of fluid. And so the goal is to have whatever we can of those lung sacs open to match the perfusion. So what happens when we turn prone is the pressure of the cardiac structures is only against a breastbone. So it's not as severe, and it
Right.
causes the pleural pressure to be more negative, which is our normal pleural pressure, and actually opens alveolar sacs. That's why you see an increase in oxygenation. The largest I ever saw was we had a patient whose PaO2 was 54, and it went up to 340 on a single prone turn. You can
Wow.
only do that if you're recruiting alveoli
Uh-huh.
to match the perfusion.
Wow. Listening to you describing this and what is happening, I find it interesting because my background is critical care as well. And I've worked in some critical care units throughout the US. And I was not a part of prone positioning until COVID.
And the challenge with that was, the fact that it does take a coordinated effort.
Yeah.
It does take education.
Hmm.
There are newer tools to be able to assist in the process and make it easier. Um, but it requires a cultural change to
Right.
incorporate it into your practice. As I said, the seminal research came out in 2013.
Hmm.
That was Garin out of France. They had 466 patients. This is the one
Wow.
where you talked about the reduction in mortality. That's
Yeah.
where it showed it. And to help understand what a 16% reduction in mortality is like, there's a statistic called number needed to treat in order to save a life. 6. The number needed to treat is 6
Hmm.
in order to save a life. That's what 16% reduction in mortality means.
Wow.
And for nurses that have been practicing a long time, just to give you a reference, do you
Hmm.
remember when we used to use streptokinase for
Hmm.
acute myocardial infarction?
Hmm.
That was a number needed to treat of 25 in order to save a life. That became standard practice. Prone positioning is 6.
I don't know what to say to that.
Yeah, and part of it is because it's challenging.
Right.
The
Yeah.
science is there. The science has been building, as you said, it started in the 70s.
Hmm.
Those patients were turned with either, for those that are old enough in the audience to remember this, the circle electric bed or the
Hmm.
striker frame.
Hmm.
Those were the two things that were used. We manually turned in 1982, and I recognized the likelihood that nurses would want to do this if
Yeah.
they had to use a circle electric bed or a striker frame was going to be 0 to none. So I wanted to find an easy way. And so the device I created actually got placed on top of the patient, supported their forehead, chin, upper chest, and pelvic region, and they got seat belted in. And it made it easy to turn, but it
Yeah.
also made it easy to turn them back in case of a cardiac arrest.
Right. Now, I know we're talking about some of that historical background, but can you give us is there some historical background of how did we even figure out that prone positioning would help with, respiratory issues and how has that evolved over time? Because again, knowing it came out in 1970s, but then realizing that in the units that I've worked in since 2007, I didn't actually see prone positioning until 2021.
Well, I'm not sure if you're aware of this statistic, but it takes 17 years to move evidence into
Uh-huh.
practice.
Yes. I'm
And
I'm aware of and
yeah, and if it's bundled,
Mhm.
like the bundles, the VAP bundle, the CLAPSy
Mhm.
bundle,
Mhm.
then that reduces to about 13. So it
Yeah.
shaves off
We have
some
a lot of
years.
bundles.
We have a lot of bundles, but this wasn't bundled.
Yeah.
So the seminal research on low tidal volume ventilation was published in the early 2000s.
Mhm.
So we finally figured out how to appropriately ventilate the
Mhm.
ARDS patient. So people weren't necessarily wanting to jump on to using a positioning thing that people would complain that it's too hard to do, even though it's
Right.
rather easy once you figure out and
Yeah.
you've been trained. Um, so from the 70s, the next published research was actually 1988, but
Wow.
it was European. It was
Mhm.
Dr. Gatnoni, who recently passed, but he was Mr. ARDS.
Mhm.
And so he studied the physiology of what was going on in the lung and put theories out as to why. And those theories have then been studied in labs and pretty much verified that those are how we make a difference. The other piece that happens when you turn them prone, because you are not opening and closing the alveoli and creating shear stress,
Mhm.
you are actually reducing ventilator induced lung injury while
Mm.
prone. So
There's so much great research.
the concept that this is non-invasive,
Mhm.
doesn't cost any money.
Mhm.
I treat 6 people with it, I save their life.
Mhm.
In 2017, so 2013 was the seminal research. In 2017, the Society of Critical Care Medicine and the American Thoracic Society, ATS, came out with guidelines for ARDS patients. And those guidelines had a strong recommendation for proning as frontline therapy.
The
But
hell
as you said, it was COVID that
right?
got because basically severe COVID is a viral ARDS,
Right.
viral initiated acute respiratory distress syndrome.
Right. And just for our listeners, I want to make sure that they know what we mean when we're talking about seminal research. And that means that we are referring to, say, research that is groundbreaking or highly influential in an
In
academic
changing
setting. It
practice.
lays the foundation for us to be able to move towards recommending something or it becoming a standard practice. And so that's what we mean when we talk about seminal research. But how did we start to see prone positioning become a standard practice for our ARDS patients?
Well, there was slower uptake from the 2013 research, but there was uptake. There was greater uptake in 2017
Right.
because of the guidelines, but it actually started with H1N1
I did not
because
know
they
that.
because they recognized and SARS, that we didn't get a lot of SARS. It was
Mhm.
heavy in Canada,
Mhm.
but proning was identified as a beneficial therapy
Mhm.
for the ARDS patient. So when COVID happened and these people, I mean, the mortality rate in the beginning, because
Right.
we didn't know what the heck it was,
Right.
everybody was pretty much throwing the kitchen sink at them in terms of the
Yeah.
level of science. So
Right.
low tidal volume ventilation, PEEP therapy, if they're not syncing with the ventilator, heavy sedation, potentially paralysis. And the next thing is proning. And what follows that is ECMO.
Mm-hmm.
And so people were going along the science recommendations
For arts.
for arts,
Right.
basically. But because so many people were dying, people were willing to try things.
Right.
There was also extra staff in the beginning of
Mm-hmm.
proning because they stopped doing elective surgery or in the
Mm-hmm.
beginning of COVID. And so OR techs assisted the ICUs with proning because
Right.
OR techs are familiar with proning.
Mm-hmm.
I was pretty busy on doing webinars or individual consults with hospitals on policies and procedures. It's the fastest policy and procedure I've ever seen done in the intensive care unit. It literally was built in a month and passed
Uh-huh.
so that they could initiate it.
Right.
And so, a little fun fact, the policy and procedure that everybody is using is off my original research.
Oh, wow. Congratulations. That's that's amazing.
In
That's a
terms of how
really,
you turn safely
yeah,
and
that's a really big accomplishment. You should be very proud of your work in that area. And it saved a lot of lives. But so research on this started in the 1970s. You proned your first patient in 1982, you
2.
said?
Yeah.
And I didn't prone my first patient until 2021. So I'm curious about how the perception of prone positioning has changed over that span of time.
Oh, it so I will be 100% honest with you, it was COVID that changed the perception
Mm. Yeah.
because everybody thought it was so hard, they didn't
Mhm.
even dip their toe. Even though they'll put somebody on high frequency ventilation that has
Mhm.
not good data, but that's a machine. This requires an interdisciplinary team
Yeah,
and a
required
group
people.
of people. And if you do it right and you have assistive tools, it's literally 5 people, 1 at the head, 2 at each side, and 1 to watch the
All the lines.
lines. Yeah.
Mhm. Mhm.
So really, I think it was fear of doing it. I've been proning, as you said, since 1982. Never lost a line. Never lost an endotracheal tube.
Yeah.
So for me, the it was the fear of the unknown.
Mhm. Absolutely.
Absolutely.
Now, some of the historical challenges that you've mentioned, of course, is just fear, um, not understanding. It's new, and we like to do things the way we've always done things, especially if we know that those things work. Um, so, what are there other historical challenges that have been faced in trying to implement prone positioning?
Um, so getting everybody on board. Sometimes what I would discover when I would consult or go into a place, specifically when I was launching my proner, either the docs were the ones that wanted to do
Mhm.
it because they had read the latest science and the nurses are like, "You're crazy," or the nurses had heard me talk and said, "We need to do this," and the docs are like, "You're crazy." So,
Yeah.
and respiratory therapy in between. So it was really trying to get everybody on the same page. And I truly believe that's what COVID did, got everybody on the same page. I
Right.
would have to say, if you're looking at countries that have been proning
Mhm.
consistently for quite a long time, France, Spain, and Italy.
Oh, well, and
That's
it's
where
just
a lot of the research came from.
right. And it's just interesting to me that it took such a negative impact of something like COVID for us to be like, "Oh, okay, let's try this. Let's do this."
Well,
Um,
and I was excited. I spoke at the National Teaching Institute, AACN's
mhm,
conference,
mhm,
the American Association of Critical Care Nurses, and um, it I had an ARDS case study, and I got a chance to ask the audience. There were about 500 nurses there.
mhm.
How many are still including proning as part of their ARDS management? And more than 80% of the audience raised their hand.
Oh,
So
that's
I was
good.
like,
Nice.
finally,
Progress.
finally. It took a
Finally,
long time, but it's happening.
we're seeing progress.
Yes. So that
Now
was exciting.
let's bring us back to today, and let's bring us back to actual, discussing prone positioning. What are the key indicators and contraindications for using prone position in clinical practice?
Well, this is where I think nursing can play a big role.
Hmm.
And that is by incorporating PaO2, FiO2 assessment into their routine practice every
Right.
4 hours on an ARDS patient, because that's one of the um, major indicators when that is moving less than 150
Hmm.
and the patient is on low tidal volume ventilation and or at the PEEP level that the
Hmm.
doc is planning. And usually that takes in an ARDS patient, if it's done well, it takes 24 hours, 24 to 36 hours. That's
Hmm.
when the decision should be made, roughly.
Okay. And
So that's the indication. So ARDS, PF ratio, so they're already on low tidal volume. They're
hmm.
on a sufficient amount of PEEP.
Hmm.
Their plateau pressures are still elevated, greater than 35 or greater than 30, and their PF ratio, PaO2, FiO2 ratio. And by the way, it's pretty easy. All you got to do is have a calculator so you can divide the PaO2 into the FiO2 because it, it's a decibel division. So in my
Right.
world, it takes a calculator,
Yes.
and that less than 150.
I use the calculator for drug calculations. I can do those all day long. Don't ask me to do any other type of math. My kids ask me to do algebra with them, and I'm like,
Ah, I need
that's
help.
laughable.
Yeah, I hear you. It wasn't my favorite subject.
Yeah. Mm-mm.
In terms of contraindications, there's really only two absolute contraindications,
Hmm.
and one is goals of care.
Okay.
If the goals of care has changed, and the other is patients with fake or facial neck trauma or
Mm.
spine instability. Everything else is a relative contraindication. So,
Okay.
what does that mean? A relative contraindication basically means we need to have an interdisciplinary discussion
Hmm.
to weigh the risk benefit ratio of
Right.
doing it to not doing it. That's what
Right.
that means.
Now, can you talk a little about how we will position and things we need to look at and think about when we are proning patients?
Sure, there's like a pre-proning procedure kind of concept that you should do. One, it includes patient and family education. Absolutely. Especially if the patient is, well, whether they're awake or not, I
Hmm.
always explain
Hmm.
what it
This is
is,
what we're
what we're going to
doing.
do, what's the
Right.
reason, and share with the family as well.
Hmm.
What I've also found with patients, if they are belly sleepers, they don't require as much sedation
Mm.
because it's a position of comfort
Right.
for them.
That's a good thought.
Yeah. And then you need to make sure you have your supplies. And what supplies are we talking about? I recommend, and so does the National Pressure Injury Advisory Panel on their infograph, that you remove the prefabbed ET tube holders because
Hmm.
there's a fair amount of plastic there
Hmm.
that could contribute to pressure injuries and has been shown to
Hmm.
contribute to pressure injuries and move back to either twill or tape.
Okay.
So that takes learning because people have lost that skill. Our
Yeah.
respiratory therapist colleagues, because they don't do it anymore,
Right.
um, they use the ET tube holders.
Hmm.
That needs to be switched. Um, you want to and some organizations, and this has been published as well, they have a pre-prone packet,
Okay.
and it has protective skin dressings in it.
Uh-huh.
It has the twill or the tape. It has extra EKG leads because you're going to switch those when they go on the back
Hmm.
as a part of that. And so you want to place protective dressings here, here, scapula, area and the hip bones.
Yes, and the here and here was the forehead and the
Sorry.
chin. No, it's okay. I just want to make
The
sure.
forehead, chin, scapula area, iliac
Uh-huh.
crests, and you want to take a look how their knees are going to be positioned because you may want to put something um, depending on if things are lifted,
Right,
where the pressure is likely going to be as a part of that.
right.
I don't recommend disconnecting IVs because that's a risk for
Infection.
A-lines, any of that, because it's a risk for infection.
Right.
I am fine with uh, NG tube disconnection, feeding
Mhm.
tube disconnection, those things that are simple that aren't going to cause challenges.
Right.
And then you really want to position your tubes. When I teach this, I talk about cutting the body in half, not
Mhm.
literally. Anything that is
Visually.
inserted, yeah, anything that's inserted from the belly up goes over the shoulder.
Okay.
Anything inserted from the belly down goes at the base of the bed because you're turning somebody in a 180-degree
Mhm.
over. So things will just cross and live with it because as long as
Right.
they're lined up along the body. Now, the only difference to that are what I affectionately call the horse tubes,
Mhm.
chest tubes.
Mhm.
If your ECMO is running out of the fem or your CRRT is running out of the femoral, then you run it down there. If it's running at the top of the, IJ and the
Mhm.
machine's at the top of the bed, then you run it that way.
Right. It's a lot to think about when you are prepping your patient to be
Yep.
able to flip. Um,
Well, and you also want to make sure that you're performing eye care.
Mhm.
And I recommend taping horizontally across the eyelid, not
Okay.
vertically, because if the patient wakes, the eyelashes will scratch the cornea, which
Mm.
you don't want to have happen.
Right.
Simple things like if they have an ileostomy or a colostomy, you want to empty that
Well, yeah. Yes.
before you do that as a part of it. So those are some of the pre-prep
Mhm.
activities besides getting the people. And if you're using, which I would recommend that you do, a breathable slide sheet
Mhm.
underneath the patient and then on top of the patient. So that when you're doing the turning, you're actually creating what they affectionately call a burrito.
Right. Yeah. Uh-huh.
Did you use the burrito method?
Uh-uh.
How
No.
did you guys do it?
We just had a bunch of people at the bedside and we were flipping them. I mean, as a team, everybody had their limb and, it wasn't I think if we had not had COVID, people people may have been more inclined to, do all the right things and figure out what the actual process was. But I feel like in COVID-19, in the middle of it, everybody was just doing the best they could as quickly as they could.
It's true.
So all of the education and things that you're talking about were not necessarily things that were at the top of our list. It was really just we don't want to lose our lines. We want to make sure that they don't have any type of injury from us moving them and basically flipping them onto their stomachs. There wasn't the education and the training that we probably should have had. It was all just kind of learning by the seat of your pants, just like all of COVID-19
Yeah,
felt like learning at the bedside by the seat of your pants together as a team, which I think was really great in the fact that it did bring all of us together as a team. And we were
very true.
all, trying to work towards the same outcome of saving patients' lives and doing what was best for the patient. But there's
Well,
so much you're talking about that
I
was
know,
not.
when you set this up, literally the best thing to do is then slide the patient away from the ventilator because you're going to
Mhm,
turn them towards the vent,
mhm,
makes it easier. So you
mhm,
have the tube back, the ventilator tubing back around the head so
mhm.
that it just lands in the correct spot when you turn them, and you tuck the arm under the butt and you actually cross the legs going towards the direction you're turning. So you have forward momentum
Right.
when you're actually doing the turning.
Right.
And if you're placing pillows or wedges or whatever,
We had a lot of
um,
pillows.
yes, you can, if you burrito them, so you literally can place the pillows ahead of time, put the other turn sheet on top, and then roll it so it's tight, and you flip them like a pancake.
Right. Wow. So
And you
much
can
that
also do it with a lift. So there's a wonderful article that goes through all the different methods to safely be able to prone a patient.
where can we find that article?
The author is, and if you need me to um, send it, here's the author is Wiggerman, Wiggermann, first initial N, and it's in Human Factors, 2020 November.
Okay. Now, we talked about the checklist. We've talked about the pre. Now, can you walk us through the during the prone? What is the recommended amount of time that they're in that prone positioning? How do we monitor them in that prone positioning? What are things we need
Sure.
to be looking at in that prone positioning?
So when they're prone, um, they should be in the swimmer's position.
Mm-hmm.
That's the one arm up, one arm down.
Mm-hmm.
And that swimmer's position should be shifted every 2 hours. And the recommended time in the prone positioning is 16 hours. I know in COVID there was long proning.
Mm-hmm.
There's a fair amount of consequences associated with long proning, specifically on the pressure injury side of things,
Right.
because it's really hard when somebody's, whether they're lying supine or in the prone position, you keep them in the same position for a period of time. I don't care what you do.
Yeah, right.
That extended period of time is going to cause challenges.
Mm-hmm.
Um, and I recommend you literally are turning the head every hour. And I don't mean a large turn of the head. I mean you're doing slight shifts in movement so that you're taking pressure off of one particular area
Mm-hmm.
and just shifting it a little to relieve it. So it
Right.
doesn't have to be a big turn.
Mm-hmm. Now, where do you normally? I wouldn't say normally. That's not what I mean. But when you're looking at pressure injuries from prone positioning, where are you usually seeing those? I would
Um,
think forehead and cheekbone and.
Forehead, cheek, and chin, because specifically, if you're using a foam thing like like the OR does, where it
Mm-hmm.
cements the head in there,
Mm-hmm.
it's not good because nobody moves the patient. Nobody moves the
Right.
head then. It stays in this stationary position for way too long. So I do not recommend the use of those for that
Okay.
reason. A circular, where you can shift the head, um, works in a solid block like pillows or a foam
Mm-hmm.
wedge where you can again shift things,
Right.
um, is important. Um, don't see it as much in the scapula,
Mm-hmm.
because that's protected pretty well. And really don't see it in the iliac crest because a lot of that it ultimately shifts when you do the swimmer's position.
Right.
You also see some, depending on if people align the feet well,
Mm-hmm.
with the toes dropping. So what I recommend for nurses is after they've done the turn and got the patient where they think everything should be, then they need to step back and look at those pressure points. And the infograph from the National Pressure Injury Advisory Panel literally has where those points are. So you step back and you take a look for alignment,
Mm-hmm.
because the other injury that takes place that we don't see till later is brachial plexus.
Mm.
If their arm is stretched
Right.
and you've got pressure on that nerve, then you're going to have problems. The other is ocular. You want to make sure that the eyelids are down, that you're putting juice in there, Lacrolube or whatever, and that the pressure isn't directly on the eyeball.
Right.
So there's a lot of nursing, um, good nursing care associated with reducing the risks. Those are the risks. Pressure injury, well, tube loss, but pressure injury is number one. Brachial plexus, ocular, and tube loss. And tube loss is minimal.
Right. And I was just thinking when you were describing some of the things that we need to continue doing is also oral care. We need to
Oh,
continue
absolutely.
with their oral care. Even though they're prone, we're not seeing their mouth like, when they're supine. We need to make sure that we're continuing oral care.
Yes, because prone supine, they're at risk for ventilator-associated pneumonia. There were some studies that were done that showed when they were prone, they had less vent pneumonia, probably related to drainage and also not the microaspiration, because it's the microaspiration of the oral microbiome, which converts from gram-positive to gram-negative within 24 hours of being in an institution. That was
Right.
one of the reasons why I created the prone positioner, the Volman prone positioner, was to be able to still do nursing care. Because the Circle Electric and Stryker frame, the nurse would have to get on the floor to be able to deliver care in the prone position.
Now I
And
see why it took so long for us to start
yeah,
using prone positioning.
yeah.
Now at
So,
least we can raise the bed up high enough that we're able to still do nursing care.
and provide the nursing care. Yeah. So everything that I do supine, I do prone.
Right.
They can even do defibrillation and CPR in the prone position. That's been studied. And if your listeners are interested, I believe the guidelines for BCLS and ACLS in COVID-19 patients, when that came out, it was published in 2022. It's the American Heart Association's guidance on how to do it
How?
if needed, if you can't get them back, if you're unable
Right.
to transition.
Right. Now, how can a healthcare team safely implement prone positioning? How do we use our team? Who do we need
Well,
on our team? And what do we need to use?
in my perfect world,
In a
because
perfect world,
that's where I live, and I work
right?
really hard to get everybody else to hang out in my perfect world.
Right.
In my perfect world, ICUs would have a multidisciplinary quality committee or
hmm
practice improvement committee
hmm
that would have all the disciplines present. It would have the medical director, it would have the manager, it would have the clinical nurse specialist, the educator, it would have respiratory therapy representation, it would have pharmacy representation, physical therapy. So the entire team. And that's where protocol should be built, because it's every discipline participating in making sure the right thing happens for the patient. So you
Right.
get that on paper, and then as a team, you figure out how you're going to do the education. And then from there, how am I going to put that education into orientation for both physicians, respiratory therapists, and nurses?
hmm
Because those are your main people on the team.
Right.
How am I going to put it into their routine education? And I would also recommend that this go in your yearly skill. If you're
I would
not
agree.
doing it frequent enough, I would recommend you put it in your yearly skill.
So what I hear you saying is that this should not fall solely on the shoulders of the nurse.
No, no, it's a partnership. Now,
Right.
in that perfect world, the nurse or the respiratory therapist may be the first one to suggest it on
hmm
the patient if they're evaluating those PF ratios.
hmm
and they know their patient's got ARDS and all the other stuff in rounds, hey, it's time to prone. Or if you have an ARDS protocol
Hmm.
that literally lays out the science so that you know when the time is to recommend it. And that is really how it should be done so that we deliver all the evidence-based care to the ARDS patient.
So we have a rapid response team. In essence, we could have a prone positioning team as well, so that when the decision is made and we need to prone someone, then we're able to call that team, those members of that team, to come help with transitioning this patient into a prone position.
Well, I'm of the mind that everybody needs to know how to do this. That
Hmm.
I don't necessarily need a special prone team because how am I gonna do that on midnights?
Hmm.
How am
Well,
I
no, I just
gonna
mean respiratory therapy comes up and they're
Oh,
assisting. The
everybody. Yes,
physician is
everybody
there and
owns.
and
Yes.
helping.
The doc's there, the nurse
Yes,
is there.
so that
Yes.
you know that you have everybody on that
Yes.
needs to be
Yeah.
there there.
And you can do that with a checklist as well. One of my
Mhm,
colleagues, Maureen Seckel, with her colleague, published a really good article on how they did that, how they
mhm,
implemented their process, their multidisciplinary process or
mhm,
interdisciplinary, and how they had a checklist to make sure all the right people were there as a part of it. Because on average, 1 out of every 10 patients in an ICU will develop ARDS.
mhm.
That's the global data. So if that's happening, then
We need to be
if we're
ready.
if we're doing it correctly, we need to be ready. Yes,
Mhm.
you're absolutely correct.
Now, how has the use of prone positioning just really evolved? Going with the COVID-19 pandemic, and what lesson did we learn any lessons through the COVID-19 pandemic where people, or I guess units, really started to lean into prone positioning?
Well, one, and hopefully after the survival component of COVID,
Mhm.
that they built interdisciplinary protocols and they actually train them correctly
Mhm.
on the process because you really don't need more than 5 people.
Right.
I mean, when you get up on significant weight, and if you have
Then we're
ceiling
gonna need
lifts,
more.
yeah. Well, no, if you have ceiling lifts, you can literally do it by a ceiling lift. So there's a process. That article that I mentioned
Mhm.
has the process for the ceiling lift. So that's part of it. But as I said to you, I was so excited to see in that audience 80% of the staff raising their hand that proning is part of the ARDS care. It came out again when the guidelines were updated in Europe
Mhm.
in 2023 as a strong recommendation that it be a frontline therapy. So the science is there. We now have an AACN's procedure manual. I was author on that. The updated one is in there. So the burrito method is in there. So you don't have to reinvent the wheel. You can take that evidence-based protocol, bring it to your multidisciplinary or interdisciplinary group and say, "Hey guys, if we don't have one, here it is. Let's
Mhm.
use this to start with and make any changes as we need to."
Right. Now, when it comes to potential complications, I know we talked about skin injuries, but what other complications should we be aware of with prone positioning besides skin breakdown?
Well, you also have, I mentioned the brachial plexus. So how
Hmm.
you do the swimmer's position is really important, that you don't move the arm up too much, too high
Right.
above the head so that you're creating pressure challenges on the brachial plexus. The ocular we talked about. The other is um, at the ankle, because normally the foot should hang.
Okay.
And so how you position the knees and the shins. And if the person's tall enough, the feet can actually go off the bed.
Mm-hmm.
in a correct alignment position.
Mm-hmm.
But we need to be mindful of that because 16 hours in that position, contractures can start.
Right. That's a long time to be out of alignment.
Yeah. So that's another area. And then we talked about the lines. I would say more than loss of endotracheal tube obstruction.
Mm-hmm.
In other words, because it's bent,
Right.
and not in good alignment, that is probably more of an issue because one of the things that we specifically recommend in the protocol is that the respiratory therapist's hands are actually on the endotracheal tube
Okay.
and they don't leave it until there's an all clear
Right. This patient is
at
where
the
they need
very
to
end.
be.
Yep.
We've got them in correct alignment. Now we can move forward with making sure that the ET tube is where it needs to be and that it's in place, locked in
And
place.
because of the 16 hours, one of my colleagues, and I recommend this as well, is they actually run the proning at night.
Okay.
So they turn them around 4 o'clock and when there's still enough resources around, and
Mm-hmm.
they make sure the patient is tolerating it and all of that. And then they'll turn them back around 9 so that they can get chest x-rays at 9 the next morning.
Right.
More
That's
resources.
what I was gonna say. Your resources are back. They're there.
Yeah. Yeah.
That's very
And
smart.
it makes sense.
It
It makes
does.
total sense.
Absolutely.
Yeah.
Uh, and that was going to be one of my other questions is that interdisciplinary collaboration and how it plays a part in that successful implementation of prone positioning. And I love what you just recommended about doing it so that yes, it goes overnight for ease of monitoring, um, but also using your tools, like you knowing doing this at a time when you know you're going to have the resources that you need to be able to do this successfully.
Yes, because your greater number of physicians are there, greater number of
Right.
respiratory therapists. You also have nursing leadership if they need to
Hmm.
jump
Hmm.
in,
So you have more nurses
depending
that
on
can
how
jump in and
busy.
help.
Yes, depending on how busy the unit is.
Right.
So it's just like the A through F bundle. Um, for the listeners, the ICU liberation bundle
Mhm.
assessment of assessment, management of pain, spontaneous awakening, breathing, choice of sedation, delirium management, early mobility, and family.
Mhm.
How you have that sequenced as standard of care, this should be as well.
Right. Now, when it comes to, I know earlier we talked about education of even the patient as well as the family. What are some of the best ways you have found in your practice as far as being able to appropriately educate the families? Because it is kind of scary to walk in and see your loved one in this proning position. Um, what's the best way to educate them and make sure that they're prepared and ready?
Well, one, I try to do it before it actually happens,
Yes.
if that's possible.
Yes.
The second, surprisingly, um, a lot of people are getting online
Hmm.
and looking it up and seeing pictures. For me, I share with them. First I ask, if the patient's not awake, if they're sedated, I'll ask the family, is your loved one a belly sleeper or a back sleeper? And then I'll explain why we're turning them on the belly, that it's going to open up their lung sacs
Hmm.
to make it easier for them to breathe and have less lung injury. And so the science has told us that this makes a big difference. And that's why we're doing it. And we're going to do everything to prevent any kind of injury taking
Hmm.
place while we're doing it and keep your
Absolutely.
loved one as comfortable as possible.
There's a lot of medical terminology in why we do this and what this does for the body. And so my advice would be just to make sure that you're speaking and what you're saying is in a way that they can understand it. So that
Going on
it's
the belly
right.
versus
Yeah.
the
Yeah.
back.
Yes. Like
And
prone versus supine.
Right.
Lungs, helping your lungs be able to breathe versus, the terminology and going into those details, helping the lungs be able to expand
Yeah.
so that they can take in more oxygen and oxygenate their body. But I think that's still important to make sure that we are speaking in a way that the audience that we're talking to, the family that we're talking to, can can really take it in. Also, it's a really stressful time. If we're having to do this for a patient, then
Yeah,
this
you
is
know they're
very
sick. Yeah.
right. Yes, they are very sick. This is moving into that life or death situation. And so a lot of times they have trouble taking that information in at
So
that
you gotta
time.
repeat it multiple times as well.
Right.
It's
Yes.
not a one and done,
Right. They're
because
not
of that
processing it
anxiety. Right.
as quickly as, they might process things. I know, and it's so hard because a lot of times you're like, "I don't understand. I've told them 15 different times. I don't what do they not understand?"
Oh, you just tell them all the time because they're
Right,
not
you just
hearing
keep
it.
telling
Yep.
them because they are having trouble processing. They're trying to process the fact that their loved one could pass away, and now I'm giving them all of this information. They're trying to process that. So patience, I think, is so important when it comes to educating family
Well,
members.
you're probably familiar, Candace, with the research on how much you don't hear if you're
Mhm.
anxious. Yeah.
Yes.
It's just like
Yes.
you go into a doctor's office and, you know,
Yeah.
you get a diagnosis and then they start talking about the plan and it's
And
like,
you're like, "Huh?
yeah,
What? I don't understand. You're talking to me, but it's like it's in a
yeah,
different
it's like,
language."
wah, 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 wah,
Yes, it's
wah.
Charlie
Yeah,
Brown's teacher.
yes,
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 and
exactly.
that's exactly what's happening, and we need to remember that as, healthcare providers, what that family is going through, because even though we have the knowledge, we could be in their shoes one day, and we hear Charlie Brown's teacher too, you
Yeah,
know, and you
very
have the
true.
knowledge, but you're like, "I can't process what you're saying to me." So,
That is very true.
mhm. Now, what are the challenges that you're seeing of integrating prone positioning into routine clinical practice?
Well, just the willingness, because it does take effort.
Mhm. It's not
Um,
something we've always done.
no. And so routinizing it as much as possible that this is the way we provide the care, like the A through F bundle, routinizing it.
Mhm.
Get yourself an ARDS protocol where
Mhm.
everybody knows that once we've reached the PEEP that we're
Right.
going to,
It's time
and
to
they're
do something
syncing with
else.
the vent
Yeah.
and we're still having oxygenation problems, it's time to prone. So it just becomes the new routine.
Mhm.
And that takes a bit to get there, but it's doable.
Right.
And the fact that it's a non-invasive therapy
Mhm.
that I can treat 6 people with and save a life.
Mhm.
That's why we went into this.
Right. Now, if you
And then
have
use some of the new tools. Some of those turn in position systems actually have air that
Mhm.
make it even easier to move. So, from a safe patient handling perspective, the patient's safe, you're safe, it's easier to do. So,
Mhm.
some of that innovation helps.
That was my next question. How can, what technology is out there? What innovation is out there to enhance the effectiveness, but also the safety of being able to put them into the prone position?
So, there are prone beds. And the challenge for me is they have to be put into the prone bed. Um, and I recommend clearly using those for people with head and unstable spine or spine issues
Mhm.
that develop ARDS. It's very effective, safe strategy. In terms of right routine ARDS patients, I think utilizing either a lift system or the turn in position, not just sheets.
Mhm.
Make it easy on yourself. A lot of places are adopting that to reduce shear and friction of the skin. So it's not just an easy, it actually is helpful for the patient's skin in preventing shear and friction as well as safe patient handling for you
Right.
when they're supine or when they're prone.
Mhm.
So those are the things that I really and we did recommend that in the proning procedure in the AACN because we don't have to, you know, when there's innovation, use it.
Absolutely. Right. If there was a healthcare provider in a hospital who is not currently using prone positioning, what advice would you have for them if they wanted to try to be the champion to get this procedure in their facility?
Well, I would definitely say listen to the podcast. Um, I also probably have a prone positioning presentation on my website
Hmm.
because if I give that talk, I then put the handout. So you would have that handout. It's just Volman.com that you could get the references. And then if you're a staff nurse, I would take it to my educator or my nurse manager and ask them to advocate to meet with respiratory and physicians to talk about this practice.
Right.
That's that well, and literally that's exactly what I did in
How,
1982.
how did you handle the pushback?
Um, Interesting enough, there were a group of us, we did it on the night shift. There were a group of us and there were residents and fellows, so they were fairly easy to convince.
Hmm.
And we flipped them and then we showed them the data. And they were like, "Huh, oh my heavens, really?
Right.
That's all you did was turn them on their belly? And this is what their oxygenation is now?"
Hmm.
And so that helped. That concept, what I discovered as a nurse, I found even though there's a ton of research out there supporting a practice,
Hmm.
if I viscerally experience it, if I turn somebody and I literally see the benefit, I'm going to be an advocate.
Right.
So all it takes is, a couple of people to say, "Hey, let's try this," to
Hmm.
begin to change the culture.
Right. Just out of curiosity, do you know if there's any research on using prone positioning for patients who are not as critically ill as, our ARDS patients, but those who are struggling with some respiratory distress and issues?
There were 2 small studies done in the 2014 and 15 that hinted that it may help. Um, we do know it does delay or reduce intubation in COVID.
Right.
Awake proning does in COVID, but we don't have enough studies to recommend it for a therapy outside of a COVID lung
Gotcha. All
at
right.
this point in time.
Well, Kathleen, as we conclude this episode, is there anything you want to recap or anything maybe we didn't touch on that you just want to make sure is shared?
For me, it's just the final statement. Take the chance. You can save a life. Prone 'em.
Yes. Pronoun.
And if you need help, you can get a hold of me.
Oh, I love how you said just pronoun. If you don't know, just
Just
pronoun.
prone 'em.
Well, to just do a quick recap, prone positioning has proven to be a powerful tool in improving oxygenation and reducing mortality rates in patients with respiratory conditions like ARDS and COVID. And we need to understand the principles behind why it works and implementing the best practices because we do play a huge role in techniques such as this that really enhance patient outcomes and recovery. And we can lead the way in getting these techniques to the bedside and to our patients. But we also need to remember that prone positioning is not just a technique, it is a collaborative effort that requires careful monitoring and interdisciplinary teamwork. And as we see this technique continuing to be integrated into more clinical settings, it's going to be very important to stay informed about the latest research and innovations to optimize its effectiveness.
And have them think, Candace, have them think of it as a treatment because it is a treatment.
Yes. Kathleen, thank you so much for joining me for this discussion and for sharing so much insight into the why behind this intervention.
It was fun. Thanks, Candace.
Such a pleasure to have you. To our listeners, thank you for joining us, and I encourage you to explore many of the courses that we have available on elitelearning.com to help you continue to grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.